Already in past, so let's just get started. I know some people are still going to wander in, but it's really an honor and privilege for me to be up here this morning introducing today's visiting professor. But just a quick introduction. I mean, this is the Andrew Connor Curtis Endowed Feature Speaker Series. This has been established since 2016 by a gift provided by Mr. Andre Kovacs, specifically with the objective of showcasing and discussing advances in neurosurgery and neuro-oncology. And we've had a tremendous list of visiting professors for this lectureship in the past, including Eric Holland, Tracy Batchelor, Hugh Defoe, Frederick Lang, Guy Lozada, and Amy Heimberger. And today we have another well-esteemed and noble addition to this list with Dr. Manish Aghi, and we can't be more fortunate to have him come here and spend these last 2 days with us. Manish is went to Stanford undergrad and then went to Harvard for his MD PhD. He then stayed on MGH and finished his residency, and then since then he's been at UCSF, where he's had an NIH-funded lab since 2008 with multiple R1s. His lab is, we'll hear about it later on, I think, in the second talk this morning, but it's really focused on the tumor microenvironment and interactions and driving aggressive biology in both benign and malignant tumors. I've collaborated with his work and Sumed's as well. We've both been lucky to have him as mentors and as an educator for us. And so he has close ties to here in Miami. And I think after yesterday, he probably has a couple more mentees. And additionally to his research, he's a PI at UCSF for their Brain Tumor Center. He runs multiple investigator-initiated phase 1 and 2 clinical trials on both immunotherapy, oncolytic viruses, angiogenic therapy. He's won multiple awards, too many to name, and the papers that's come out of his work have been tremendous. He's also the past chair of the tumor section and did a phenomenal job as well there. And there's no doubt with the last decade, he's one of the most preeminent neurosurgeon scientists in brain tumors in the world. And we're just so lucky that he could take out the time from his busy schedule to come all the way to the East Coast and spend these last 2 days for us. And so I just want to thank him again personally for taking that time, and we look forward to your talks today. We have a plaque here for you. I don't know, Rick, if you want to.
Yeah, maybe afterwards. You want to do
it? Yeah, we'll do it after. We'll do it after. Yeah, we'll get a big.
Well, thank you. It's really been a pleasure being out here all day yesterday. I've known the gang here for years, Mike and Rick and Ashish and everyone, and it was really actually when talking to the residents, remembering yesterday a case I did when Mike was a chief resident where it was a craniopharyngioma, and I remember him calling me the night before and just walking through his thinking, and it totally reflected exactly how I'd been thinking about that case, and that was when I was like, oh, this guy's ready, and I think as the attendings, those are the feelings of pride we have in seeing Mike all these years later, and being invited by him to come out here. It's just a tremendous honor. So thank you very much. I'm going to talk in the first half about this. About surgical management of brain metastases. And so this talk was born out of a process that we all go through. We're all busy tumor surgeons, but from time to time we get asked to sort of think about specific diseases that are subsets of our practice in detail. And for me, this came out of an initiative we started a couple of years ago where we were finding as surgeons that we were operating on brain metastases almost in isolation. With our interaxial gliomas, we had sort of a robust neuro-oncology presence and a multidisciplinary work with radiation oncology and neuro-oncology. But with brain metastases, we were sort of working in isolation to some degree because our medical oncologists weren't as integrated within the neuro group. And so we put out a recruitment effort to bring on board a neuro-oncologist to see the brain metastases patients and refer them in for surgery. And as part of that initiative, we started collecting our data. And Raman Morshed, who's one of our residents at the time in the middle of residency, is now a skull-based fellow with Mike Link, put together a lot of the data and outcomes. And so that was one thing that got me thinking. I have no disclosures about this topic. I'm going to be starting by talking about surgery, some of the interactions between radiation and surgery. And then some of the systemic therapies that have made inroads, a little bit about laser, and then some bit about guidelines, and then just wrap it up. And then another thing that got me thinking about this more recently, and just a little plug, is that I was fortunate to edit the current month of August issue of Focus, which was an update on brain metastases. And many thanks to Bill Caldwell and Erin Cohen-Goodall for approving this topic, and worked with Albert Kim and Priscilla Bastianos and Steve Kalkanis in editing this issue. And so I was very fortunate to review over 70 submissions, including one from your group that was chosen for publication in this. And we did a journal club on this earlier this week. And so this really gave me a chance to sort of see where the field is at and think about it in more detail. And so we've seen that brain metastases are the most common intracranial brain tumor, and at autopsy, about 1 in 3 systemic cancer patients will have detectable brain metastases, although most of those are going to be sort of micrometastases, and but the ones that come to clinical attention represent about 200,000 cases per year in the US. And the incidence rose with the advances in imaging that we had in the sort of early parts of the century, but have really since leveled off, but it remains annually the most common. And then here you see the incidence by primary cancer. And so this classic soil seed hypothesis of Paget, which goes back to over a century, it is relevant to brain metastases because primary sites will have different propensities to develop brain metastases, as we've seen with lung cancer remaining over the years the most common, even when adjusted to the incidence of the primary tumor, the most common source of brain metastases. The trends over time, if you go and, these trends emerge when you look at it over decades, there's certainly been an increasing use of radiosurgery and systemic treatment over time, but surgery still remains in the workhorse particularly for patients with solitary metastases. And we are doing better over time in the management of this disease, thankfully, particularly in those with good performance status. And so for the brain metastases, we talk about RPA class a little more than KPS, which is more discussed in sort of classic intraaxial glioma tumors. But regardless of the outcomes continue to do well. And I think as targeted therapies make inroads, this is going to get even better. And this is what we like to see, because really the goal here is, these are not going to be necessarily curable patients, but if you can make inroads and ensure that the brain is not the source of the ultimate survival outcome, then at least you've done your part to prolong survival in these patients. So brain mets patients, unfortunately, historically have done worse than patients without brain metastases, particularly those that are older, and then those that have brain metastases in the setting of more extensive extracranial disease will understandably do worse. But with aggressive control of intracranial disease, you can improve quality of life and survival. And so previously, about a third of patients with brain mets would succumb to CNS progression of their disease. And that number is down to about 1 in 5 over the past 10 years. And our institutional data will sort of replicate this as well, as you will see. So when we talk about surgery for brain metastases, and the CNS, we tried for years to do this in terms of guidelines. And unfortunately, when it comes to some of the basic questions, even though the brain metastases world has been the beneficiary of randomized trials that we have a harder time doing with gliomas, the classic questions, one of which I've shown here is, surgery plus post-op SRS versus SRS alone for solitary brain mets. 2 randomized trials have really shown no difference in local control rates. And so as a result, the decision-making comes down to judgment and relative indications. And so, conventionally, we would think of surgery for tumors larger than 3 centimeters, mass effect, especially in the P fossa, superficial, safely accessible location, uncertain diagnosis, radio-resistant histology. And then more and more, as I'll allude to, there's sort of, even in the setting where there's a known primary, there is increasing desire on the part of medical oncologists to get tissue in the setting of metastatic spread to understand what is the immune profile of the metastasis, because this may influence their choice of targeted therapies, particularly in some diseases like melanoma. On the other hand, even for a solitary metastasis that might be deeper or smaller, and an older patient who might be more of an anesthetic risk or eloquent brain or radio responsive histology, we could consider SRS. So, given the lack of a proven benefit for one over the other in the randomized setting, it comes down to judgment. And if you are going to take these out, these are the cases that we all learn early on in residency and get really fired up about because they're doable early in your training, and you feel like you're taking these out. But it is exceedingly important to achieve a gross total resection. Thankfully, it is achievable for brain metastases. But in the absence of a gross total resection, the prognosis benefit that you get with surgery drops considerably. One of the sources that of debate is this en bloc versus piecemeal resection, and obviously we all strive for en bloc. It's difficult in retrospective series to prove whether the reason we all advocate for en bloc is concern about leptomeningeal spread of disease when you're removing these piecemeal. But it's difficult to prove that risk goes up with piecemeal resection, in part because it is really difficult when the sort of one of the least reliable pieces of data you get in retrospective studies is the surgeon's op note, in which everything is removed en bloc and gross totally resected. And so to sort of correlate that with outcomes is, unfortunately, just very tough. And I'm as guilty of that as anyone. So I'm certainly not going to judge for that. But that's one of the challenges. But nonetheless, we all strive for en bloc resection. And this is similar to the debate in the chordoma literature and other literatures as well. So as in terms of our UCSF institutional theories and some of the things we've looked at, one of the questions, and as I mentioned, Raman Morshid as a resident spearheaded a lot of this and came up with like 9 or 10 publications, which I'll just highlight a few. And these were sort of designed to address some of the questions that come up related to surgery. So one of the questions that comes up is, we'll operate and send the patient for post-op SRS after resecting a brain met, typically around 4 weeks. And many of these will stay in-house, particularly if it's single fraction SRS. Obviously, if it needs to be fractionated over several weeks, they may get treated in the community. But as a result, we get pretty good data about what they look like. And so one of the things that comes up is, how urgent is post-op SRS? And, our median time to treatment is about 4 weeks after surgery. And when we do that, unfortunately, what does happen sometimes is these patients will progress on their day of SRS scan compared to what they looked like on their immediate post-op scan. In the series in the literature, this rate of progression is about 40 to 50%. And thankfully, most of the time it's small progression and can be incorporated into your SRS plan. And we found our number was a little bit lower. We had about from nearly 300 a little over 300 starting patients, about less than 1 in 3, about 31%, had a new metastasis on their pre-SRS scans. And interestingly, the vast majority of these are distant recurrences outside of the surgical cavity. So we are, as surgeons, doing a good job with not just getting a gross total resection, but avoiding micro recurrences at the time of SRS, with only 17%, still a decent number, but 17% of the rapid recurrences were local in nature. And so then Raman drilled down on this in a little more detail. And, one of the things we have the beneficiary of is this sort of 500 gene panel for the brain metastases, as well as when they have surgery at UCSF, the primary tumor. And so he was able to identify some genetic alterations such as RB1 changes or CTNNB1 that were associated with an increased risk of local recurrence, but nothing that was associated with the risk of distant recurrence. And this would suggest that distant recurrence is just, patients develop brain metastases, and they're not necessarily doing this in a way that is an elevated risk based on molecular profile. But local recurrence is potentially a different biologic phenomenon related to the specific aggressiveness of the tumor. On the other hand, distant recurrence is associated with other things occurring outside of your surgical cavity. So if the patient has extracranial disease, to some degree, this primary tumor is now the cat's let out of the bag. And so you're dealing with something that's a bit more of a ticking time bomb. And so one of the things we've changed in our practice as a result is that when we have patients with extracranial disease who have surgery and then are being referred in for SRS, we try to get them in for their SRS a little bit quicker, closer to week 2 or 3, to avoid this risk of a distant recurrence at the time of SRS. And interestingly, these rapid recurrences, when these patients come in for these SRS scans, we're sort of thinking about it like, well, we'll just add it on to the SRS. But the question is that a bad prognostic sign that you're having to do that? And it turned out it wasn't. So rapid recurrences obviously impacted the treatment plan for this patient's stereotactic radiosurgery, but did not impact their survival, which we found to be an interesting observation. And so then Raman turned his attention to remote recurrences. So, but first, looking at the genetic mutations that were associated with increased risk of long-term local and distant CNS recurrence. So now you're talking about Kaplan-Meier curves that are stretched out over, as long as these patients survive. So, median, we can get data up to 2 to 3 years after their initial surgical event. And what he found, and this was a recurring theme in his work, was that CDKN2AB co-deletion was associated with an increased risk of long-term local and distant recurrence, but with a fairly significant p-value. And this has come up repeatedly, and I'll mention it before, but there is some evidence from our series as well as some others, as well as preclinical data, that CDKN2AB co-deletion in brain metastases is a particularly bad prognostic marker, even amongst the landscape of numerous genetic alterations in these cancers, that this one really has stood out over time. So I mentioned, one of the worst things that can happen with these patients, and really unfortunately becomes, in many of these cases, a terminal event, is leptomeningeal disease. And so, it's important to try to define LMD in a rigorous way. To some degree, sometimes people are looking at it very subjectively on scans, but the formal definition that's used in most of these series is, new and distinct abnormal leptomeningeal enhancement that has to be at least 5 millimeters away from any prior surgical sites or SRS treatment isodose lines. So you want to make sure it's not a treatment artifact and that it's really going to be representative of an oncologic transformation. And there are two types of LMD that have been described in the literature. The classic sort of what we think of as LMD is this sort of curvilinear enhancement of the leptomeninges involving sulci, cranial nerves, brainstem, the folia of the cerebellum, or the ependymal lining of the ventricle. The second subtype is nodular, and this is sort of this thickening along of the dural matter, so extraaxial and nodular enhancing lesions. And this is something that, in the absence of a primary cancer, might even look like meningiomatosis, but this is nodular LMD in these patients with a known primary cancer. And so in the literature, conventionally, when you look at risk factors for developing LMD, one of the problem with most of the series in the literature, and they will typically quote, that it's about a 5% incidence in all comers with metastatic cancer, not brain mets, but just systemic cancer that has spread outside of its primary site. About 5% of those patients will develop LMD. But if you look at all cancer patients at autopsy, even if they did not carry the known diagnosis of brain metastases, about 1 in 5 will have under the microscope evidence of LMD. And so previously investigated risk factors for LMD have included, having multiple brain mets, understandably, PFOSA metastases, a person who had a craniotomy with a, quote unquote, piecemeal resection. And I mentioned the caveats with that, investigating that topic, and then violating the ventricle during surgery, which has been proven to be very safe and not associated with spread of cancer in the GBM world, but it's been postulated as being associated with LMD in the brain metastases world. But the problem with a lot of these series is that they're sort of defining LMD based on a retrospective chart review, and you may get, lured into a trap if there's an oncologist who's just put down LMD, or even a radiologist who didn't review the imaging carefully. And so what we set out to do was look through this and get, a panel of neuroradiologists to weigh in and confirm that we had patients with true radiographic, unequivocal LMD. And so when we looked at this in our series, and we focused exclusively on those who underwent craniotomies for brain metastases. So we didn't try to get the data from all systemic cancer patients, but exclusively those undergoing craniotomy for brain metastases. It was about just under 22% of patients who developed LMD in that postoperative period. And of these cases, interestingly, I was expecting more classic, but it was really about 2/3 of them were nodular and only 1/3 were classic LMD, where you just have that thin enhancement of the leptomeninges. And the majority of nodular cases occur on the same side as a prior craniotomy. which suggests sort of some correlative link and potential causality, but obviously it's not the same as causality. And then the risk factors we found were we were able to replicate some of the series, some of the risk factors that other literature series would suggest, but as well as identify a few others. But the PFOSA, as the literature would suggest, was definitely a risk factor. We also found insular metastases, which had not been looked at before, in occipital location as risk factors. Lacking extracranial disease was, we found the opposite of what other people had suggested was a risk factor. The theory being that they just live longer when they have extracranial disease and are therefore more at risk for developing it. And then ventricular contact during surgery was definitely a risk factor for LMD. And I think this is sort of borne out and replicated in other series as well. Not surprisingly, we found that post-op LMD dramatically worsened these patients' overall survival. And classic LMD actually had a worse prognosis than nodular LMD, even though nodular LMD radiographically looks worse. Classic LMD, the median survival from the moment they develop it is just, it's not, they don't even get to 2.5 months. Nodular LMD, though, the median survival is about 7 months, which is, you know, really dramatically better than what you get with classic LMD. And so Raman looked at molecular risk factors for postoperative nodular LMD, and it's some of the same players, again, particularly CDKN2AB co-deletion, which comes up every time we looked at a risk factor for a bad outcome in our brain metastases patients. And so we're working actively with our medical oncologists to try to get some of those patients onto targeted therapies earlier in their course to see if that addition can help reduce this risk. So switching gears for a moment, I've alluded to radiation and radiosurgery in terms of the actual decision-making early on when choosing between surgery plus SRS versus SRS. But what are some, in more detail, some of the interactions between radiation and surgery, and how do we in sort of the modern era think about our decision-making and in a multidisciplinary fashion? And so one of the things that's really come up, and we talked about this yesterday in the case conference, that's been you know, being actively investigated, including here and at several sites, is this idea of SRS before surgery, typically for solitary brain metastases, although not exclusively in that setting. And the theoretical arguments in favor of this approach, and I found it somewhat counterintuitive when I first heard about it, but one would be that it reduces this phenomenon of tumor seeding at the resection site, which could lead to a local recurrence, or in the CSF, which could lead to leptomeningeal spread. And then the other argument, which comes from our radiation oncologists, but makes sense, would be that it would minimize collateral radiation into the surrounding brain, that essentially the dose that the patient would receive in an intact preoperative lesion would be to the surrounding brain would be less than if you took out the tumor, because although we all, and we've even published on this, think about the resection cavity collapsing by the time they get to SRS, the reality is that they're outlining a margin of normal brain that is typically going to get a higher dose than if you just did SRS prior to surgery. And so several studies have looked at this in single arm fashion. The most interesting one that actually just came out earlier this year in JAMA was this 8-institution study that enrolled over 400 patients. And again, most of them had solitary lesions, so the lesion to patient match is pretty close to 1-to-1 over about a decade and a half. What was really interesting about this series is I suspect they encountered the same skepticism early on that I might have had, because they actually documented their enrollment per year, and it accelerated in around 2018. So I think something like 2/3 of these patients enrolled in the last 3 years of the study. And early on, it was like just floating out there and not accruing. So I do get the sense that there's growing interest in this. And so they looked at 2 adverse outcomes, the 2 from the previous slide that we would worry about: local recurrence at the site of the metastasis that was treated, and leptomeningeal spread. And both at 2 years, they were quoting, you know, lower rates than what I was mentioning from our UCSF series even. So, and similarly, they compared it to other institutional series, and at least anecdotally, it was not randomized, but it was suggestive of a favorable outcome. And so as a result, this is now being studied in several clinical trials that will have 2 arms and the ability to compare across arms and try to drill down more rigorously with a higher level of evidence of whether we should be considering doing SRS before surgery more frequently in these patients. And this is, what the Kaplan-Meier looked like when you combine the adverse events of local recurrence and leptomeningeal spread, and it was under 20%. And as I mentioned, this actually just came out in June of this year in JAMA Oncology. And so we've treated a handful of patients in this series, not as a part of any study. And I think it's interesting, and we should all await the results of these trials that are ongoing. So I've mentioned a lot of cases of solitary brain metastases. And so one of the questions that comes up is, what is the role of the surgeon in the setting of multiple brain metastases? And so typically in these series, we will, put the solitary brain metastasis in its own category. And then there's a category that's sort of this middle zone where the surgeon is at least, sitting around wondering, like, should I get involved? We discussed a case like this at case conference yesterday, but so we typically will say 2 to 4 brain metastases. And so that's the setting where, you're wondering about the impact of the quote unquote dominant metastasis and whether resecting that would, be helpful to the patient. We've tried to drill down on this in our series, but it's so difficult to formally define the quote unquote dominant metastasis, because we tried to do it with sort of how large it was relative to the other lesions. But then there was the case in case conference yesterday, they may all be the same size, but one of them being in the P fossa changes your calculus completely. And so we ended up not publishing the series, although we're still trying to, but we do have, as I'm sure you do, a number of cases where we've performed surgery in this setting. So rather than sort of presented in that context, I do think this is almost a topic that's best served by individual case examples, much like the case that was presented yesterday. This is a case from 2.5 years ago of a 73-year-old male who, comes in known new diagnosis of non-small cell lung cancer. So there's not any diagnostic uncertainty. And he presents with a little bit of speech difficulty and had this quote unquote dominant lesion in the left superior temporal gyrus, as well as other lesions shown here, 3 other smaller metastases shown here alongside that larger one. And so I reached out to our radiation oncologist and asked them, how this would look with or without surgery. And so without surgery, the radiation plan would have been single fraction frame-based treatment of all 4 metastases, and then they would have brought the patient back for 4 more fractions to the largest met in a mask. With surgery for the dominant left temporal metastasis, they would have waited 2 weeks to see if the cavity collapsed, and then treated the all 3 metastases with a frame and the 1 resection cavity with a frame, and then brought the patient back for 2 more fractions. So they were looking at, in this case, a fractional reduction with debulking and resection of the larger met. Not to mention the patient had some symptomatology that didn't improve with steroids. So in this case, we took the patient to the OR, took out the left temporal met, and then set them up for 3 fractions of radiation to the big cavity, and then single fraction treatment for the other 3 lesions. And this patient has not had cranial progression, either local or distant, in over 2 years. So obviously that decision in a single case proved to be validated. SRS is very good, but obviously there are settings where patients progress after SRS, just like I showed you examples where patients recurred after surgery. And so we were able to identify 43 patients progressing after SRS, all of whom underwent, the vast majority of these patients undergo, what we call salvage surgery in that setting. And these are aggressive lesions if they've failed SRS. So your success rate is not spectacular, but so local progression will occur in about 1/3 of the cases after salvage surgery, so higher than if you had just operated initially. And LMD is much more common in this setting, nearly 40% of patients. But the median overall survival after salvage surgery is still just shy of 1.5 years. And so it is definitely an indication for surgery and a pretty common source of referrals in these patients. One of the questions that becomes, obviously, you just don't want to take out this lesion that's progressed after SRS alone, because there's some level of aggressiveness. So the 2 treatment modalities as adjuvant treatments that we found effective, one was brachytherapy. So we do that a fair bit in this setting, implanting seeds after resecting a tumor that progresses after SRS. We do some post-op repeat SRS. I personally am more a fan of brachytherapy. I mean, to me, it's a little more intuitive to tell the patient, okay, we're going to take this out and we're going to do something different with your radiation than we did the first time when it failed, rather than just post-op repeat SRS. And this is sort of what these progression curves will look like. This was work that Dan Cummins, who's now a resident at Mount Sinai, looked at in detail. By histologic primary type, there was a variety of outcomes, but none of them deviated from each other in a significant fashion. What about systemic therapy for brain metastases? So this is an area that I would say is not quite ready for prime time, but is getting increasingly closer. And so recent examples of demonstrated efficacy of systemic therapy. One is non-small cell lung cancer patients with EGFR mutations. Brain metastases can be treated with, if they have a concurrent mutation in the ALK, so ALK and EGFR combined mutations. Several of the EGFR targeting agents in that setting have intracranial activity and have been shown to lead to, in a sort of retrospective fashion or single arm fashion, better outcomes in patients with brain metastases. And newer EGFR targeting agents are in development with even better CNS penetrations. This is an area of increasing emphasis. In terms of breast cancer, brain metastases with HER2 mutations, there's been a number of clinical trials that have shown some degree of efficacy, but only in a single arm setting, so hard to be certain. And the one that I'm going to touch on in a little more detail is checkpoint inhibition for melanoma in the setting of, how it looks for patients with or without BRAF mutation. So targeted therapy, but targeted immunotherapy in that case. And so this has been best studied at melanoma, and we published recently in the JAMA Open our experience with this and looked at it from a molecular perspective. So a little bit of lab work built into a clinical study. So this was 94 melanoma brain metastases patients. We first asked whether they were distributed similarly across the 4 molecular subtypes that have been defined for extracranial melanoma, which is BRAF, RAS, NF1, and triple wild type. And they did match perfectly that series. And 48 of these 94 patients were started on systemic checkpoint inhibitors by the melanoma team with the hopes of getting control of intracranial disease in that setting. And when we looked at multiple variables that could impact survival, the one that emerged as best associated with survival was BRAF. So the BRAF V600 mutation was associated with a worse progression-free and overall survival in these patients. And the hazard ratio was nearly 2, which was higher than any of the other variables we looked at. We then actually went back to the tissue, and this is where the lab part comes in, but we looked at the immunologic makeup of the brain metastases, and we found that the ones with this worst prognosis with this BRAF V600 mutation had a lower infiltration of CD45 positive immune cells, particularly macrophages and T cells. And so that leads to the logical next question, which is that can you prolong survival when a patient with BRAF wild type melanoma with all of these immune cells in their metastasis compared to the mutant ones receives checkpoint inhibitors? And sure enough, on the left, you see when they have BRAF wild type, you get a very nice progression. You get very nice overall survival outcomes when patients receive immunotherapy. So 60% of those patients are alive at 5 years after treatment. But if you have the mutation, the checkpoint inhibitor has absolutely no effect. And so this is something that is consistent with what others have seen as well, and sort of matches the decision making. And so it has led to one scenario where tissue gets requested from a brain metastasis purely for the oncologist to determine whether or not the patient should undergo immunotherapy. And this is exactly why. We then looked at what happens when patients progress after immunotherapy for brain metastases, and we operate in that setting. And it's a very poor overall survival in that setting of just under 8 months, and a high rate of postoperative LMD and a high rate of distant CNS metastases. So not surprisingly, if the disease is bad and you're operating in that setting, the surgery is still often clinically indicated based on patient symptomatology, but you're in certainly a bad setting. Interestingly, when we looked at variables that improve survival, some of the stuff that emerged was very paradoxical, but certainly giving post-op SRS after operating in immunotherapy failure cases improved survival. Interestingly, additional checkpoint inhibitor therapy did prolong survival, and that's the one I wanted to highlight. And this is this idea that checkpoint inhibition is very different than targeted therapy. In targeted therapy, when the patient progresses, molecularly targeted therapy, you're really concerned that the tumor has changed, that it no longer expresses the target, and you really do need to really quickly move on. Checkpoint inhibition in the setting of brain metastases, to some degree, is a matter of time. And the oncologist will say that it can sometimes take 6 to 8 months to really see an effect. And so sometimes they'll have us operate when someone progresses. I have a case like this where it was just requested to operate, but their intention is to keep treating every 3 weeks, and you're just squeezing in your operation in between the treatments. There's no major side effects in terms of wound healing and things like that. And so their idea is that you're just trying to buy them time to allow this immune effect to kick in, particularly if the molecular profile is favorable and suggests that checkpoint inhibition is a good idea. Lastly, I wanted to touch on, in my remaining time, LIT for brain metastases. This is something that has not been as extensively studied as a primary treatment, in part due to its the effectiveness of SRS in surgery. It is, of course, somewhat appealing because it balances the minimally invasive nature of SRS with the ability to get tissue that you have with surgery. But the reported cases of LIT as a primary treatment are really limited to a handful of cases embedded within larger series. But where it has made inroads is LIT for brain metastases progressing after SRS. This was first described over a decade and a half ago, and since then has been published in nearly 200 patients. And the progression-free survival is very good and correlates with your extent of ablational lesional coverage. And I think part of that has to do with the fact that you're just typically going to assume that most of these progressions after SRS, you've done a good job of ruling out, pseudoprogression or radiation necrosis. And so there is probably viable tumor in there. So you do need good ablational lesional coverage. The results in terms of using LIT when patients progress after SRS is very comparable to craniotomy in terms of outcomes, but not surprisingly, craniotomy is better at resolving symptoms in these patients. And as I mentioned, it is important to take advantage of the ability to get tissue before LIT to differentiate potential radiation necrosis from a viable brain metastases, because you do need nearly 100% lesional coverage for control of a viable brain met. But the threshold for success when you're treating radiation necrosis is a little bit lower. And imaging-wise, it can be very difficult to be certain. And so since you're in there with LIT and getting tissue can be extremely helpful, of course, there's the caveat that of spatial heterogeneity. So your positive predictive value is certainly a lot higher when the sample before LIT shows tumor compared to when it shows necrosis. And LIT for pure radiation necrosis after SRS is exceedingly effective. And it's based on the hypothesis that LIT is essentially thrombosing proliferating endothelial cells. And to do that, you don't need quite as good coverage as you do to treat viable tumors. And so as a result, in the setting of true radiation necrosis, where somebody is, you're 100% confident that's what you're dealing with, but they've progressed and they're not really doing well on steroids, LIT can be a very viable alternative. One series compared it to bevacizumab in that setting and found that the approaches were very similar in terms of their degree of symptomatic relief and ability to get off steroids. But bevacizumab had a greater rate of radiographic response, whereas LIT had greater overall survival. And this remains to be validated in larger series. Our institutional practice still favors bevacizumab over LIT in this setting, but thankfully these cases are relatively rare. But generally it seems like we favor to keep them out of the procedural setting, but that's partly institutional bias. We don't do a ton of LIT, but it's very effective in this setting. And here's an example of a case of a 52-year-old with radiation necrosis after SRS for a left occipital brain metastasis. And you get this, immediate after ablation, post eggshell appearance. Subtraction MRI looks favorable, no perfusion after the ablation, and then involution of the lesion 6 months after LIT. And so this is an example of very successfully treated radiation necrosis in the setting and treated by LIT. Guidelines I just wanted to touch on. I started by mentioning this topic. Extremely challenging to get formal guidelines that can be practice changing in this setting, because even most of the randomized trials we've looked at and it wouldn't surprise me if the SRS before surgery trials proved to be this way, have shown sort of no definitive benefit. And so as a result, when the various societies, whether it's the CNS, ASCO, SNO, or ASTRO, have looked at this topic, they leave you with this sort of degree of ambivalence that surgery may be offered for patients with brain metastases, especially without a primary diagnosis and in larger tumors with mass effect. But it's really limited in your ability to make recommendations regarding topics like LIT or piecemeal or en bloc resection, which just to highlight two of the topics I've alluded to that were areas of greater uncertainty in the literature. So with that, I want to acknowledge our team at UCSF. Marisa Drost was the neuro-oncology lead in our brain metastases program. I've highlighted my surgical colleagues in the brain tumor team over here. Steve Bronstein from radiation oncology is our rad-onc, who sort of along with me helped Marisa build our brain metastases program a couple of years ago, and Raman Morshed, who, as I mentioned, did a lot of the literature studies that were published from our institution when he was a resident at UCSF. And so with that, I'd like to thank you for your time and open it up to any questions.
Interesting to bring in, the molecular components. I was most interested in the 17% that you talked about earlier was that progression after resection that you noted between post-op MRI and the 4-week, even though that didn't affect the outcomes. But do you think that the preoperative SRS for those cases, that you would see a difference for that control? And that may be a major change. Yeah, that is definitely one of the things that got me thinking about it for sure. I think those cases, it didn't reach statistical significance, but were a little bit larger than the other ones. And those advocating for SRS before surgery are sort of thinking there may be an optimal size range where there's a benefit, and that sort of 4 to 5 centimeter range, and or something there where single fraction SRS is already pushing it, but then maybe if you use it before surgery, you're going to reduce local recurrence as well.
What are your thoughts on timing for preoperative SRS?
Sorry, timing. Yeah, that's actually, I was going to mention that. That is an area that's all over the map in the literature. And I think in talking to our colleagues, they're sort of in that 4 to 5 week range, but it's a little, and some of it depends on how long the patient can wait. I mean, you get a little nervous in some of these big ones where that SRS alone isn't going to control it, but that's sort of what you hear anecdotally.
Have you sort of incorporated this adaptive radiosurgery where you do like if something has like a higher volume, you'll do a single session but treat it to a lower dose, and then with a plan to go back and give it like a 10-grade boost?
Yeah, we've done a few of those as well.
Yeah, I mean, we've, especially for the radio responsive tumors,
it
tends to have a very good response.
Yeah.
You guys have a Gamma knife?
Yeah.
And what's your workflow between like neurosurgery and radiation oncology? Who's sort of like calling the shots? Or
yeah, so all the cases get presented at Gamma Knife Tumor Board, which is separate, and then the surgeons and the oncologists are there, and then the procedural workflow is surgeon places the frame, and the surgeon and rad-onc work together on outlining a treatment plan and signing off on it.
But you do have that, your whole team there is, you guys have a tumor board where you just brain metastasis.
It's a pure radiosurgery tumor board.
That's an interesting concept. Okay, thank you.
Any question?
We have like if regarding melanoma brain metastasis, I think our melanoma oncologists are pretty aggressive now after like this MD Anderson paper with intrathecal nivolumab now. And they're asking us to put Ommaya, and I just don't know if you guys are also kind of going in and kind of doing similar studies with intrathecal immunotherapy.
Yeah, we have not, but I think there's some awareness of that, but they have not been asking for it so far. And get to part 2 here, to the basic science portion of this. So as Mike mentioned, I'm a surgeon scientist, so this is the other hat I wear as a brain tumor scientist at UCSF. And so, early on in training, doing some basic science as an MD PhD student or as a neurosurgery resident in Boston, I became interested in the microenvironment of glioblastoma, and that's the central focus of my lab. And so, we don't so much fixate on the molecular profile or tumor or mutational profile of the tumor cells, but we thoroughly interrogate the GBM microenvironment. And our particular lane is sort of these subtle cells that are cells that receive less attention. So we're not so much a vaccine lab or an immunotherapy lab, which is a highly competitive, saturated market, but we are interrogating the cellular makeup of the microenvironment and looking for some mediators that are understudied, but potentially quite contributory, where there may be opportunities for novel therapeutics. And so I have no disclosures. Some of this work started with several years ago in my lab. We wanted to take this CyTOF machine for a spin, and we're doing this in collaboration with other investigators who are studying other types of cancers. And so this is this mass cytometry where you can interrogate and the microenvironment of these tumors in detail and look at a number of markers. And so we sort of just took 19 gliomas, 9 renal cell cancers, and 4 sarcomas for a spin in this machine, and profiled the T cell makeup and the macrophage makeup. And it's sort of interesting looking at this, because what we found is that these tumors were either macrophage rich or T cell rich, but rarely both. And GBM was unique in being uniquely macrophage rich, but T cell poor. And this sort of highlighted to us, because of all the evidence in the literature of how tumors hijack macrophages and convert them into this M2 or pro-tumoral phenotype, as well as the extensive literature showing, from groups like Peter Fecci and others, that GBM patients essentially have a T cell profile similar to someone with HIV, like a very immunodepleted. And so this has always been a central focus of ours, that this makeup is a crucial component of why glioblastoma patients have such a poor prognosis. We know that this is not a hyperproliferative tumor, but and obviously there's a number of things it does. It hijacks neuronal synapses, it destroys white matter. But for us, the key focus of our lab has been, how do we go about attacking this poor immunophenotype? And so two of the questions that we've recently worked on addressing, so this is a 2-part story. The first is, that previous slide and many other studies have focused exclusively on macrophages, which are myeloid cells that, are increasingly the subject of focus, but there's other myeloid cells besides macrophages. And the one that we've looked at extensively, which, as I said, is understudied, is neutrophils. What's nice about picking a topic like that, if you're passionate about it as a surgeon, where you have sort of maybe a little more limited bandwidth than a pure PhD, is you're in a less saturated space, and you're able to make some observations that you're less likely to get scooped by. And sometimes you get into some things that are super interesting and get a lot of attention. And we've been fortunate to have some examples of that I'll share with you. And then the second question comes, okay, fine, it's a macrophage-rich, T-cell poor tumor, but are there other stromal cells in the GBM microenvironment beyond those cells that are sort of upstream of that actually promote that immune phenotype that might be better suited to therapeutically target? And so starting with part 1 of this, which is, oops, I think I may have frozen myself out. Yeah. Starting with part 1, which is this tumor-associated neutrophils in glioblastoma. So TANs, or tumor-associated neutrophils, were originally thought to be innocent bystanders in cancer. And there's a number of reasons why. One is that neutrophils have a short life expectancy. When you culture them or even try to track them in vivo, they're pretty much gone within 48 hours. The second is that the theory was that maybe you're just happening to grind up a tumor and catch passerby cells that weren't even in the tumor parenchyma, or were just caught in blood vessels. And the third question that people would pose is, are these even functionally activated, sort of spinning off that previous limitation? Like, are they just circulating neutrophils that happen to be passerbys? And so we sort of have addressed all three of those questions. But before we even got started on these series, there were a number of series in other cancers that have gone back and forth and said, oh, neutrophils are pro-tumoral, neutrophils are anti-tumoral. And then people would spin out of that and say, oh, maybe it's like macrophages where there's N1 neutrophils that are bad and N2 neutrophils that are good for the patient and bad for the tumor. That just seems so simplistic and kind of ridiculous and spinning off of what was done with macrophages that it seemed to me like a very poor way of thinking about this. And then within GBM in particular, one thing that we were interested in is that it's been known for several years that the ratio of circulating peripheral blood neutrophils or PBNs to lymphocytes is associated with a poor prognosis in GBM patients. And so this dynamic, and that doesn't, of course, that doesn't tell you anything about what's going on in the tumor. In particular with a blood-brain barrier, it may very well not reflect that. But this idea that maybe neutrophils have context-dependent effects that are dependent on lymphocytes is something that will come up throughout this series of data that we present. And so the first observation we said is, well, let's take on this question of lifespan. And so we found that if you culture tumor-associated neutrophils that you isolate from patient specimens, they can actually live up to a week in culture. So, more than twice as long as peripheral blood neutrophils. And when you grow peripheral blood neutrophils in the presence of tumor conditioned media, so the secretome of the GBM, if you will, it enables those peripheral blood neutrophils to live for as long as the neutrophils from within the tumor. And that effect is blocked when you add a blocking antibody against GM-CSF. That's a typo. And so the idea is that the tumor seems to be secreting something that promotes the lifespan of its neutrophils. And so this was our counter to this idea that, well, they don't live that long. How could they be doing anything? They actually do live pretty long, maybe not as long as macrophages, but certainly far longer than circulating neutrophils. So then the second question we tackled is are they activated or are they just sort of passing by? And so we all learn in med school that neutrophils have this classic sort of polymorphonuclear morphology, and that's sort of an indication of some level of activation. It's this hypersegmentation. So we actually looked at this. Miki Ladd, who was in the lab and did much of this work, found that tumor-associated neutrophils, or TANs, were far more hypersegmented, which is indicative of activation, compared to peripheral blood neutrophils from the same exact patients. And so you see the number of nuclear segments per neutrophil going out to like 4 to 7 far more often than it does in peripheral blood neutrophils. So the mean segmentation is higher in a robust and statistically significant fashion in a tumor-associated neutrophil compared to a peripheral blood neutrophil. When you look at this another way by measuring the shape or form factor of tumor-associated neutrophils, it's lower, which is indicative of a higher surface area, of a higher perimeter to surface area ratio, which is also consistent with tumor-associated neutrophils being activated. Nonetheless, tumor-associated neutrophils retain a phenotype called the capability of netosis, or excreting their contents, which is a classic sort of canonical neutrophil function. And so this activation, they're not only activated, but they're capable of all of the biologic functions that you see in neutrophils. So these are real, robust, activated neutrophils with a longer than expected life expectancy. We then interrogated, and this, as I mentioned, is work that Miki did in the lab, and it's in preprint format now being reviewed for publication. We interrogated tumor-associated neutrophils transcriptomically compared to peripheral blood neutrophils. This was exceedingly challenging because it required a real care in isolating these cells. They're much less transcriptomically active than typical cells, about 2,000 transcripts per cell compared to tens of thousands in a viable tumor cell. And so it required tremendous processing care. We actually had to take these samples straight from the operating room to processing, and the clock was sort of ticking. But when we were able to succeed in doing this, we found that tumor-associated neutrophils exhibited a transcriptional signature consistent with antigen presenting capability, the ability to not only present antigens, but activate T cells. They had all the components of MHC2, co-stimulatory ligands, and antigen processing machinery. And this is not sort of considered a canonical neutrophil function, but it's instead typical of what has been described in other cancers as quote unquote hybrid neutrophils, or neutrophils that have the ability to present antigens to T cells and activate them. And this was the first hint of a possible interaction between neutrophils and T cells that sort of circled back to this observation that the neutrophil to lymphocyte ratio in circulation was prognostic in patients. And then Miki interrogated this more. He found that MHC2 positivity existed at a protein level if you do flow cytometry in tumor-associated neutrophils. In some patients, nearly 40% of their tumor-associated neutrophils had surface positivity for MHC2, as you see here. So the transcriptomics correlated, had a protein correlate, and it was functional. So if you give them DQ ovalbumin, which is a protease substrate that fluoresces once it's proteolyzed, and if you give it to MHC2 positive TANs, you get uptake and processing of that fluorescent substrate that does not occur in MHC2 negative TANs or in peripheral blood neutrophils from the same patients. And so he then went on to show that these tumor-associated neutrophils are capable of activating T cells in an MHC2 dependent manner. And he did this via two different assays. The first was an allogenic lymphocyte reaction where he took T cells from healthy volunteers that did not have GBM and showed that tumor-associated neutrophils from GBM patients could activate these T cells. They were capable of both early and late activation of CD4 and CD8 positive T cells in a way that peripheral blood neutrophils, even when primed with endotoxin, could not achieve. He took this one step further and did autologous lymphocyte reactions and showed that tumor-associated neutrophils could activate matched circulating CD3 positive T cells from the same patients with or without a systemic activator, suggesting that tumor-associated neutrophils not only were capable of activating T cells, but they even expressed co-stimulatory ligands, and they were able to independently provide the dual signals that are needed for T cell activation in these cell culture assays. We then said, okay, we've kind of reached the limit of what we can do with human GBM tumor-associated neutrophils. In order to look at this therapeutically, we need to go to the mouse models. But before doing that, we need to ask basic biologic question, which is that does mouse GBM tumor-associated neutrophils replicate these features of human GBM TANs? So we had two different mouse models. We had BAGO1 GBMs, which were developed by Hideo Okada's lab in a BALB/C background, and GL261, a canonical sort of carcinogen-induced line, and C57 BL6 mice. And they both had similar tumor-associated neutrophil levels as human GBM. They also expressed MHC2 on their tumor-associated neutrophils at levels very comparable to what we see in patient GBM TANs. And mirroring circulating neutrophils did not express MHC2. And MHC2 positive GBM TANs from mice had greater morphological complexity than MHC2 negative GBM TANs, all of which suggested that they had the same sort of features of human GBM TANs. They were morphologically activated and they had MHC2 positivity. So we then asked the question of, what is the effect of if you take out neutrophils in a mouse with GBM on intracranial GBM tumor growth? So we found using bioluminescence that neutrophil depletion slows the growth of murine GBMs. This is data from Bagel GBMs in BALB/C mice. And the effect at 3 weeks post-implantation was robust and significant. And so, okay, then you'd say, well, if you take out the neutrophils, the tumor is growing. Therefore, the neutrophils are anti-tumoral. They are slowing down tumor growth. And neutrophil depletion also lowered intratumoral CD8 positive T cell levels, suggesting again an interaction between neutrophils and T cells. And the intratumoral CD8 positive T cell levels inversely correlated in individual mice with their tumor volume. So all of this suggested that in Bagel murine GBMs with BALB/C mice, neutrophils and T cells, CD8 positive T cells in particular, were interacting to potentially slow tumor growth. We also found that different signaling pathways predominated when there were more T cells versus fewer T cells. So in the presence of an individual mouse with a high level of CD8 positive T cells, we had gamma interferon and TNF alpha dependent signaling. But in mice who were succumbed to disease with fewer CD8 positive T cells, they had more sort of stem cell pathways predominating. And I will circle back to this in a moment, but this was the idea here, was that you were getting this robust anti-tumoral immune response when you had the combination of T cells and neutrophils. But in the absence of T cells in mice that had a less of a T cell response, a GBM stem cell response was predominating. And so the question became, is this effect of TANs that we were seeing with neutrophil depletion T cell dependent? And so, as I mentioned, when we depleted neutrophils in a competent model, we were able to slow GBM growth. But in T cell deficient mice, the opposite occurred. When you depleted with neutrophils, you would actually have the opposite biologic effect when you do this in athymic mice. And so at this point, we were left with some uncertainty as to what was going on. And as often happens in the story, when you reach a point of uncertainty, you need a hero to come along and save the day. And for us, that was your own Sumit Shah, who joined the lab around that time before his transition to the dark side of spine surgery. And he did a number of elegant experiments showing how neutrophil depletion in athymic mice was reducing GBM stem cell markers. And so this actually went back to this idea that neutrophils were promoting a GBM stem cell response when T cells were absent. And so, and coincidentally, we also found in patients that neutrophils actually resided within close proximity to blood vessels, but in the brain parenchyma, using MPO staining, that neutrophils were in the perivascular niche close to GBM stem cells. And so this was telling us that the effects of neutrophil were truly context dependent. In the presence of T cells, they were able to mediate a robust anti-tumoral MHC2 mediated response. But in the absence of T cells, which is really what's occurring in patients who are immunodepleted, they interacted directly with GBM stem cells in a pro-tumoral fashion. So then Miki looked at this at the level of single cell RNA sequencing and found, interestingly, that our hypothesis had been that tumor-associated neutrophils were coming from peripheral blood neutrophils. I mean, that seemed to be the logical reasoning. And this is where the story took a pretty dramatic turn, because when we interrogated matched GBM TANs and peripheral blood neutrophils using single-cell RNA-seq, we found that tumor neutrophils were actually considerably less mature than circulating neutrophils. There seemed to be no plausible mechanism by which tumor neutrophils could be arising from circulating neutrophils. Tumor neutrophils, in fact, over time, were able to differentiate into a peripheral blood neutrophil-like cytotoxic cell, like a canonical neutrophil, or a non-canonical neutrophil with antigen-presenting capability. But their maturity level, they had a subset of cells within tumor neutrophils that had what we call early neutrophil. So the neutrophil world has this module score called NeutroTime, which tells you how differentiated the neutrophils are. And if we just looked at our tumor neutrophils, there was these, the majority of the cells were very immature, as shown in red, and the ones that became more mature had either a cytotoxic canonical phenotype or an antigen-presenting cell phenotype. But all of them across the board were considerably less mature than what we were seeing in peripheral blood. And Miki interrogated this in mice cells and found that if you took patient peripheral blood neutrophils and exposed them to tumor conditioned media, they don't even develop MHC2 expression. So the one feature that we associate with tumor-associated neutrophils could not be induced in peripheral blood neutrophils exposed to this tumor secretome. And so it turns out, and for that we had to turn back to the mice, that you needed really immature neutrophils, and the only way we could get these in mice was from the bone marrow. So you could isolate CXCR2 negative immature neutrophils from the femur of mice, the femur bone marrow, and those, when exposed to tumor conditioned media, could be induced to an antigen presenting phenotype of MHC2 positivity. And so we said, okay, these are coming from the bone marrow, but the moment they enter circulation, they're going to become a peripheral blood neutrophil and they're going to lose this capability. So how do you get these immature neutrophils into the tumor without exposing them to the blood? And we also found that tumor conditioned media was chemotactic for immature neutrophils when they were in close proximity using Transwell experiments. And for the next set of experiments, we had to shift gears and we said, well, there is actually a bone marrow source very close to GBM, and it's the skull. And so this is around this time that there were a number of seminal observations in meningitis, stroke, and TBI, where people found that the skull bone marrow was contributing myeloid cells into the parenchyma in the setting of CNS stressors. And so we started asking, could the skull bone marrow be contributing myeloid cells of this immature state that we were finding within human and murine GBM? And so we started with some simple experiments and took skull bone flaps. And so within the skull of mice, the bone marrow niche resides within the span between the lambda and bregma sutures. And so we took skull flaps and put them in culture and found that tumor conditioned media would promote the migration of immature neutrophils out of these skull flaps and into culture. So that was a sort of a simple and crude model that showed that that worked. And we then, when we characterized these cells, they were not only responding to tumor conditioned media with chemotaxis, but they were responding quite robustly. So you would get within the media nearly 2 to 3 times more immature neutrophils than you would get in the absence of conditioned media. These skull marrow derived neutrophils were also able to migrate to the GBM microenvironment in vivo. And so this was a novel set of experiments that Miki did, where he essentially performed skull transplants on mice with GBM. And so he would take and implant a tumor in a recipient mouse, and then after the tumor was situated, take a GFP positive mouse and harvest the skull piece from bregma to lambda and explant it from the donor mice and secure it with glue to the recipient mouse that had GBM growing. And then in the mice that resulted, we could isolate by flow cytometry a portion of the myeloid population within that tumor would exhibit the phenotype that the transplanted skull had. And so we were basically finding that skull marrow derived immune cells and precursors were contributing to neutrophils in the GBM microenvironment in a robust fashion. And this was where the story took a pretty significant turn from what started as sort of simple questions about neutrophils in GBM. We also found that these tumor-associated neutrophils from skull marrow would differentiate into antigen-presenting cells after getting to the tumor. So they would arrive at the tumor looking exclusively like these immature MHC2 negative cells, but over time in the tumor would take on that MHC2 positive phenotype. And virtually every MHC2 positive neutrophil we saw had its origin traceable to the skull marrow. Miki then said, is this some finding that can be leveraged in a therapeutic fashion? And so it turns out that there are ways that you can actually target the skull marrow therapeutically. And so he did this in 2 ways. So obviously you've got a control group, and he had 2 arms that took it in 2 different directions. You know, we're hypothesizing that these skull marrow cells, which are actually primed and exposed to CNS antigens, give rise to an anti-tumoral phenotype. And so if that's the case, if you were to selectively irradiate the skull and kill those cells and body shield the mouse from not receiving radiation anywhere else, you would in theory worsen the prognosis. But if you liberated those cells, and so one of the agents we chose for this is AMD 3100, which is a CXCR4 antagonist that has been shown to liberate immune cells from systemic marrow. In this case, we injected the AMD 3100 intercalvarially with a Hamilton syringe into the bone marrow into mice with tumors. So we have one arm that receives skull irradiation and one arm that receives intercalvarial AMD 3100. And sure enough, the survival curves behave the way we would hypothesize. The control arm in the middle, the skull irradiated group, had a much worse survival, and the intercalvarial AMD 3100 had a much better survival. And Miki was able to replicate this finding in 3 different models: the GL261, the bagels, and then an SB28 model that's also in C57 Black 6. And he found that their survival correlated directly with the level of MHC2 positive neutrophils that were infiltrating into the GBM. And so this was a really intriguing observation that we're hoping to build upon further. But he looked at this in further detail and found that myeloid precursors were seen robustly intratumorally when you gave the mice intracalvarial AMD 3100 in a level that you did not see in the control arm or certainly in the skull irradiation arm. The skull irradiated tumors were interestingly much more necrotic than controls, nearly 5-fold more. And they had more canonical tumor-associated neutrophils. So these are the ones that I talked about with the work that Sumit did, where we were seeing tumor-associated neutrophils promoting stem cells. And this is the sort of phenotype that you see with canonical neutrophils. And this has actually been shown by others as well, that tumor-associated neutrophils accumulate in necrosis in patient GBM and are associated with a worse prognosis. So this level of necrosis, which is one of the hallmarks of GBM, and we see it at a higher level when we irradiate the skull, is actually associated with a worse prognosis. But when you use AMD 3100 intracalvarily, you drive the good neutrophil phenotype, a better prognosis, and far less tumor necrosis than you see in the control arm. And so this we really feel like this opens up, pending further validation studies which are underway, potentially exciting translational opportunities. I mentioned intracalvarial AMD 3100, but you could also envision conjugating drugs to neutrophil-specific antibodies, delivering large compounds with whole cells, or even peptide pulse dosing and vaccination protocols that are leveraging this myeloid population within the calvarium. And so we find this to be what started out as a very sort of unclear direction of a project, just focusing on the biology of tumor-associated neutrophils, as often happens in science, went in a very different direction. And that was sort of this part one of this story that I wanted to share with you. But switching gears for a second and talking about the second of these two stromal cell types that we've interrogated in the lab, and this is work that was published in March of this year in JCI. We've been curious for years about, are there cancer-associated fibroblasts in glioblastoma? These have been described across so many systemic cancers, including breast, colon, and lung cancers, where they have protumoral effects. CAFs have not yet been identified in glioblastoma, and were in fact presumed absent due to the lack of fibroblasts in normal brain. It's also very tricky in a mesenchymal tumor like GBM to be able to show that there are fibroblasts which have such a mesenchymal biology to them. And then the other challenge in this line of investigation is that CAF markers have been defined in other cancers, but are extremely heterogeneous, not very ubiquitous, and even within individual cancer types, very difficult to just isolate some cells like this by flow. The markers that have been described in other cancers like PDGF or alpha SMA are just not ubiquitous and are shared with other cell types as well. And so we started tackling this using, and this was work done by Jonathan Rick, who was a med student, and Saket Jain, who was a postdoc in the lab. And we started tackling this by serial trypsinization. So serial trypsinization has been described for isolating cancer-associated fibroblasts from systemic cancers. And this is this idea that we're used to adherent cell lines, but most primary cancer specimens, the cancer is not adherent when you culture it. And so if you serially trypsinize a patient specimen, over time, the tumor cells will wash out into suspension. But cancer-associated fibroblasts are actually quite adherent. It's one of the few cell types that doesn't need to be altered in culture in order to become adherent. It sort of starts out adherent from the get-go. And so if you serially trypsinize a patient specimen, as we did for up to 6 weeks, what happens with GBM is that over time, the cells take on a morphology that seemingly was fibroblast-like, but we wanted to look at this rigorously. And so we did this methodology called vampire analysis, which is just an algorithm and we applied machine learning to it to classify, and we utilized breast cancer fibroblasts and GBM cell lines to be able to teach the algorithm what the morphologic distinction is between CAFs and GBM cells. And we found that when we cultured cells by serial trypsinization, over 3/4 of them had CAF-like morphology. But when we have the same cells in the absence of serial trypsinization, nearly 80% of what we saw was GBM based on morphology. But that's obviously just the tip of the iceberg in terms of proving that these are calves. So to take it to the next level, we had to take these cells that we had isolated by serial trypsinization and interrogate them transcriptomically. And so we used single cell RNA-seq because we imagined that what we had on culture was going to be quite heterogeneous. And so although we certainly had some bulk transcriptomic data, it was the single cell data that was going to have to do the heavy lifting here. And we sort of developed an algorithm called a CAF probability score for individual cells that was based on their aggregate expression of 9 described canonical CAF markers and their lack of expression of 5 non-CAF stromal markers taken from cells like endothelial cells, parasites, and lymphoid cells as well. And when we did this, we found that 50 to 60% of the cells that we had isolated by serial trypsinization had high CAF probability scores. And when we looked at copy number variation, although classic canonical GBM cells, including in these specimens and others, had chromosome 7 gain and loss of chromosome 10, most of our cells with high CAF probability score, as shown with these cells in red, did not have the canonical chromosomal changes that you see in the malignant cells that are in blue there. And so the cells with high CAF probability score did not appear to be deriving from the tumor. We verified this using mitochondrial single nucleotide variation analysis and basically found that calves had a very distinct mitochondrial genotype from other stromal cells or tumor cells. And so this was further proof that what we were seeing was not just fibroblast-like based on its transcriptomic profile, but had a very distinct lineage, was not derived from tumor cells. And these are what the calves look like in their single nucleotide variation from the mitochondria. And then as a third proof of concept, because these days peer review will never be satisfied, you have to keep sort of proving your point. We looked at a different algorithm. So there's this published GBM map or GBM cell map that took 26 data sets of over 240 patients and over 1 million cells, and specifically teased out transcriptomically the map and profile of rare stromal cells based on that transcriptomic profile. And when we interrogated our population of cells isolated by serial trypsinization purely based on this, we found that about 42% of these cells were cancer-associated fibroblasts. And similarly, when we brought in the CNV, again, the cells that we were identifying as calves lacked the copy number variations that were seen in GBM. We then looked, now that we had some proof as to what cells were calves, we started asking some of the biologic questions about subtypes and where these come from. We looked at lineage trajectories and found that the cells that had these fibroblast markers had a immature subset that went on to differentiate into a more immunosuppressive and fibroblast-like profile that was seen in other calf types as well. Around this time, there was a paper in Cancer Cell that described 3 calf subtypes: a steady state-like, a mechanoresponsive type that's, does the typical calf things, producing extracellular matrix, et cetera, and then an immunosuppressive or immunomodulatory type. And we found examples of all 3 subtypes. These have been described as preserved across multiple cancer types and species. And so we felt some reassurance in that we were seeing it within our GBM cells as well. We then said, okay, well, is serial trypsinization just artifactual, or can we actually use this algorithm in unsorted, pure patient profiles? So we looked at 16 GBM cases and found a population of cells expressing fibroblast markers in each of the 16 without the copy number variation changes that we were seeing in tumor cells. We then looked at spatial transcriptomics and found that the cancer-associated fibroblasts were in close proximity to CD34 positive endothelial cells, as well as protumoral M2 macrophages, which I'll return to in a moment. And this transcriptomic profile in 16 GBM patients also revealed that calves were in close proximity to not just GBM stem cells, but GBM stem cells that had a mesenchymal profile, as opposed to the ones that were more astrocytic or neuronal in nature. And so all of this suggested that calves that we were identifying transcriptomically were well equipped to exert a protumoral effect. They were in close proximity to mesenchymal stem cells, as well as protumoral M2 macrophages. We then did some cell culture experiments. We further purified and enriched this calf population using some of the markers that were emerging from the transcriptomics. the population that was identified by trypsinization, and then took conditioned media from calves and found that it enriched the frequency of stem cells in GBM neurosphere cultures. And transcriptomically, within those GBM stem cells, the calf conditioned media was activating several protumoral pathways associated with malignant transformation, such as EMT or the response to hypoxia. The calf conditioned media was also enhancing the oxidative stress within these GBM stem cells and their production of reactive oxygen species, which are associated with protumoral effects. We interrogated the interactions between calves and GBM stem cells to look at mediators of these interactions. And so we lined up the transcriptomics between the two and said, what are some mediators that could be responsible for crosstalk? And two that emerged that were validated by blocking antibodies were HGF, which binds c-Met on the GBM stem cells, and osteopontin, which binds CD44 on the stem cells. And blocking antibodies to each of those reversed the stem cell proliferative effects we were seeing from calves, as well as the transcriptomic effects that we were seeing. I mentioned that calves were in close proximity to M2 macrophages, and sure enough, in culture, we found that when you took calf conditioned media and incubated macrophages in calf conditioned media, you would get a robust M2 gene expression profile, not an M1 gene expression profile, as compared to the positive controls shown on the left. And the mediator for this, when we interrogated our calves, it turned out that calves secrete a very unusual EDA splice variant of fibronectin. And EDA is actually capable of binding TLR4 receptor expressed by macrophages. And when we added a blocking antibody to that, we were able to reverse this M2 promoting effects of calf conditioned media. I mentioned that calves were instrumental in the hypoxic response of GBM stem cells. It turned out to be more than that. They promote angiogenesis when you culture HUVEC endothelial cells and measure their ability over time to form branches and longer branches, all the things that are considered hallmarks of angiogenesis in cultured cells were upregulated in the presence of calf conditioned media. And lastly, in vivo, when we add 5,000 calves to 35,000 GBM neurospheres intracranially, we get 90% tumor-related mortality compared to just 10% mortality. So we deliberately, for this experiment, chose a very small number of GBM neurospheres that was normally not, 90% of the time, not going to be capable of forming even a tumor. So essentially, it appeared that calves were altering the threshold for how many cells and spheres you had to implant in order to even get a tumor in the first place. And in vivo, we saw the same transcriptomic profile being upregulated when you were adding calves, this sort of stem cell enrichment and EMT phenotype. And in addition, there was an M2 protumoral effect when you were adding calves to these patient-derived xenografts. And lastly, the same effect we were seeing in culture, calves were promoting vessel enlargement, and in fact, were causing some of this glomeruloid angiogenesis that the pathologists have described as a histologic hallmark of glioblastoma. And so all of these things are reasons why we became interested in taking this further. And so unlike the previous talk on neutrophils, it's a little bit harder to identify these cells in murine GBM, but we did interrogate murine SP28 GBMs transcriptomically and found a small cluster of cells with a very high calf probability in the lower left. And this opens up the possibility of lineage studies, because in murine GBM, you can do bone marrow transplantation, because one of the hypotheses that ties together these two topics is we do believe that cancer-associated fibroblasts may actually evolve from bone marrow precursors. And our hope is in the future to be able to prove this using some of these mouse models, now that we've been able to identify a small subset of cells that have the same phenotype in murine GBM. And I think beyond that, calves in systemic cancers have been a therapeutic opportunity, and the theory and the hope would be that something similar could be accomplished someday in glioblastoma, whether it's through calf depletion or systemic agents that have been shown to normalize cancer-associated fibroblasts in systemic cancers. This is a potential avenue of future investigation that we're hoping to look at. And so with that, I'd like to thank the funding sources to the lab that have been very generous to support this work, as well as all the people over time who've been instrumental in getting this work to the finish line. I obviously, of course, highlighted some of these throughout this talk, and have been grateful to them all for their help. Thank you for your time.
Thank you for coming and visiting us.
Thanks so much.
No, I was just wondering from the translational aspect of the Calvaria, of potent cells in the Calvaria. The mouse and the human are so different, as particularly just even with calvarial size relative to body. Have you done any inroads in trying to map that out in a human?
Yeah, it's a great question. So work underway. It's proving to be tricky to process human calvarial specimens to identify these cells, in part because the healthy specimen where you could get an autopsy thing, or even tissue from a hemicranie or something like that, it doesn't harbor a lot of these cells. It's in the disease state that we see it upregulated, and so it's very tricky to get those specimens in the disease state. We've tried processing smaller calvarial pieces off of a bone flap in the setting of a tumor, but it is tricky to get viable cells out of that, but we're working on ways of improving that processing. The other thing that was recently published in the setting of neurologic disease and neurologic illness is the potential of a PET tracer ligand that seems to identify a signal in the calvaria that may reflect this population, and we're hoping to get to look at that in tumor volunteers and see if we can do that there.
Yeah, I mean, great work. My question is on the same thing. So if the bone is the irradiated bone is doing worse, so then, I mean, there's two things we're radiating GBM cells, and then we're taking off the bone and basically putting it back on dead bone. So two things that would be decreasing kind of the neutrophil population. So do you think they're both kind of counterintuitive as far as the body's ability to fight GBM?
Yeah, I mean, the irradiated model that we had, we tried as best as we could to control for those variables, but there's no doubt that it's not as clean as the intracalvarial drug experiment. But we certainly interrogated the microglia and the native brain population to look for evidence that the radiation was altering the brain microenvironment, and we had a control arm as well. I mean, partly it's such a short-term thing that we weren't seeing any signal changes outside of what we were seeing in the skull, but it's difficult to be certain how clean that experiment is for sure.
But do you think that the normal 60 gray that we're giving patients is having an effect on the bone marrow?
Yeah, I think that's certainly a possibility. I think, as to what could be done to prevent that, it's hard to say, but that is certainly a possibility. I agree.
Great talk. Very inspiring. The main question I have for you is the drug, the AMD drug that you're using, is there like kind of pleiotropic effects on lymphocytes as well with that drug, or is it just like kind of neutrophil specific?
So biologically, absolutely. I mean, it's been looked at in the context of HIV and other things. In the context of Calvaria, we didn't see anything. And partly, there's not much T cell trafficking within the Calvaria because they're going straight from bone marrow to systemic bone marrow to thymus and then into the parenchyma. And then there is a literature in which B cell migration out of the skull has been demonstrated in other cancers. We just weren't seeing that when we interrogated murine GBM, which, much like patient GBM, doesn't seem to have much of a B cell presence. So that's probably why.
Any other questions? So, there's this historical thoughts that infections could cause immune responses and prolong GBM survival, and so obviously that's a different neutrophil population that would be generated there. But what are your thoughts, I guess, on your findings and the history of that possibility?
Yeah, I know, much like your previous question on the radiation, it does get you thinking, because so much of what we see in the setting of infection in a GBM patient revolves around the skull rather than and the bone flap and the the adjacent skull, and all the sort of obsessive infectious disease questions around the osteomyelitis components of things, and versus very little of it seems to actually be parenchymal in that setting. And so it did get us thinking as to whether that stimulus could be, if this population existed in human GBM, could be liberating that population. And tricky to prove, as I said, in the human setting, but certainly food for thought.
Another random question I had for you was, do you think, like, and you said that GBMs are T cell deplete mostly, but there's so many labs that are focusing on GBM tumor infiltrating lymphocytes and kind of like trying to activate TILs in the tumor microenvironment. Do you think that those are worthwhile studies to look in the T cells, or are we just kind of missing the boat here?
I mean, I think they are in part because it's most of the interventions that we've looked at in other projects in the lab. It seems like when we have sort of a successful effect with tracer studies and all that, we're not really mobilizing circulating T cells, but we're instead stimulating a expand style nature of what's already embedded within the tumor, waking it up, making it proliferate more. And so I as of now, that's where most of the inroads have been made. And so I think focusing on the TILs is very reasonable.
Yeah, right. Okay, well, thank you again.
Thank you.
Appreciate it. And just another round of applause for Dr. Augie.